Good afternoon, colleagues and friends. So thank you, Dr. Prakash and his team for asking me to present on my toolbox. Not a toolkit. Toolkit has become very negative nowadays. so my toolbox for chronic total occlusion. So this presentation I will show through. I will try to demonstrate through various cases what is my toolbox, what I follow in my cath lab. Next slide, please. So why do we need a toolbox? Next, please. Next. So when I think we can mute Dr. Surprakash so that it will be easy for him also. He can hear us, but we can ask Dr. Surprakash to mute it so that he will have the privacy to work.
Baba, inform, mute that one.
So why do we need a toolbox is when a skilled operator knows exactly what has to be done in the procedure with the best material for that particular step. And with advanced knowledge of the construction and the purpose of the devices, the procedure can be performed with a high rate of success and a small chance of complication, even if the procedure was not done also. So it indicates that we should get a very, very high success rate for the procedure if we have the knowledge of the material. Even in the 2019 consensus statement also, the global consensus statement for CTO also, if somebody is knowledgeable, I think the point number 6 out of the 7 important tips from that global consensus statement, the point number 6 is one should have very good knowledge of the hardware so that he will be able to perform the procedure in a successful way. So this topic, next slide please. This topic I am going to approach with various case examples. And possibly we can have some discussion on different ways of approaching the same case. The first gentleman is a 43-year-old male, hypertensive, who had an inferior myocardial infarction, and right coronary artery had a proximal chronic total occlusion, and the distal right coronary is not visualized. The left coronary is normal. The right coronary angioplasty was attempted elsewhere and has failed. Patient had angina. Next, please. So we can see here that there is the right coronary artery is occluded and there is some intracoronary collaterals, but the length of the chronic total occlusion is more than 20 millimeter and there is a big side branch. The duration of occlusion is not in years, but it is a longer duration, but there is some faint antegrade collateral. So as we were discussing just a few minutes ago, whenever we have an antegrade intracoronary collateral or a bridging collateral, you can see here in the REO projection that there are two bridging collaterals. So it is important that we do a antegrade wire escalation strategy. That's what is my approach for these cases. Next slide, please. So the planning for this case was right radial and femoral axis. Both were 6 French, and we do a dual coronary angiography. And the right coronary artery, we do a microcatheter supported coronary guide wire. So my usual choice of a workhorse guide wire in my cath lab for the past more than a decade has been Taylor FC wire. Because the tip load is about 0.8 grams. It is a hydrophilic wire, penetrative wire, and it is a non-tapered wire. So I get a reasonable control on the wire. There are a lot of people who do not like the wire, but I think it becomes an individual choice over the years what wire you take as a workhorse wire that continues to remain with you. So unlike a guide catheter or unlike a microcatheter, the coronary guide wire remains to a certain extent individual choice or operator giving choice. So what we wanted to do is a distal wire advancement and using a contralateral angiographic guidance and stent deployment using intravascular artery. So next please. So this was the standard plan. I am sure most of you would agree. So the important, simplest and the most potent technique for a successful PCA CTO PCA is the first step is to do a dual coronary angiography. It is very essential for us. And for doing a dual coronary angiography, we need to take both catheters have to be guide catheters, and both have to have the independent pressure monitoring systems. This is for safety of the procedure. Why we should not use a diagnostic catheter is sometimes you get a contralateral donor coronary, that's what we call. There could be a donor coronary complications. Even without passing, sometimes you can get a donor coronary complications and all. So you should always take a bilateral, both the axis should be guide catheter axis. So some people can take both radial, some people can take both femoral. Once again, it's a personal choice. So it depends upon the dual coronary angiography gives us a very nice information about the distal vessel status. And then the second thing is, because when we are injecting from both the sides, we get to know the length of the CTO segment, the nature of the CTO segment. For example, in some of the cases, you will see that whether the CTO segment is tortuous or straight, that information we can see, so that we can assess the lesion complexity better, and it predicts the success of the angioplasty. And it is a very important thing, important technique for improving the procedural safety. We have seen one of our Japanese colleagues asking Dr. Surprakash to inject from the other side, so that before we advance our microcatheter, we can understand where our wire is luminal or extraluminal wire position. So it has got a very great bearing on the procedural safety. Next, please. So this is, even though it doesn't come under the toolbox, but this is an important thing. So first wire, what we took was a Fielder FC, and we could not cross the Fielder FC with the Caravelle microcatheter. So, but later on, we changed it from a Fielder FC to, we changed it to a Gaia second. So once we changed it to Gaia second, we were able to cross from the, if you see in the previous angiography, the wire was outside the lumen, but we could bring back the wire into the true lumen. So there, we should always resist the temptation to perform an antegrade angiography. If you have got a good retrograde collaterals, our entire angioplasty procedure, as much as possible, should be guided through a contralateral angiography rather than a ipsilateral angiogram. So ipsilateral angiogram, if the wire goes subintimal, the dissection plane continues to increase. So we changed to a Gaia second with a Caravelle microcatheter support. Next, please. So once we did that, obviously the procedure, the balloon dilatation, and next, and we did 2 stents, and this is the result. So let us look at the various armamentarium what we have used in this procedure and understand them. Next, please. So the coronary wires are many. You can see almost 20-30 coronary wires are there. It is important for us to understand and follow a particular group of coronary guide wires, so it is easy. It doesn't mean that Asahi is superior or Abbott is superior. It is better to choose a one set of company coronary guide wires and follow them. So in my personal preference, I choose Asahi, and then we have the Fielder set of wires, and you have the Sion, Fielder, Gaia, and the Suho. So these are the 4 important groups of the wires. And apart from that, you have got some wires for the retrograde, which we will discuss when we come to that particular case. So as I told you, Fielder FC, and we have the Fielder FC is the wire what I use, because it has got 0.8 gram tip load. That is for my workhorse wire. Like people use a run through or a BMW Universal,
That is my workhorse wire. It's not the ideal choice according to many people. That I agree also. So so this wire has got a hydrophilic tip, and the extent of the hydrophilic tip is about 20 centimeter. So it's a long hydrophilic tip, and it has got a it's a stainless steel wire. So because it's a stainless steel wire, it is sometimes prone for kinks, and but at the same time, because of the stainless steel proximal part of the wire, it gives a good support for the delivery of the various long strands and the guide extension catheters, etc. Now the other wires are, you can take a guide fielder XTA and XTR, and those are the wires where the tip load is different. The tip load of XTR is about 0.6 if I'm right, and XTA is around, once again, 0.8. So these tip load, the lowest tip load for the wire in the fielder series is 0.6. Later on, we have another generation of wires, especially for the retrograde crossing of the collateral, whether it could be epicardial or septal collateral, like what you have seen with Dr. Surya Prakash. We can take a Suho 3 where the tip load is only 0.3. Now, Gaia wires we will discuss later, but these are the fielder series. The other series of wires which people use as a workhorse is the Cyan blue wire. All the Asahi wires have got a green shaft, whereas the Cyan blue has got a blue shaft. So Cyan blue is used as a workhorse wire. Even though then it is very important to understand that Cyan blue is a non-hydrophilic wire. The blue indicates that the shaft of the wire is blue in color. So whenever you tend to use many Asahi wires, for you to differentiate, if you use a Cyan blue as the workhorse wire, it will be easy for you to identify which wire is what on the table. Then Cyan black also has got a tip load of 0.8 grams, but the hydrophilic coating is up to 40 centimeter. So it is a long hydrophilic coating, and the technology of the wire is completely different compared to fielder FC. FC and Cyan black have got the same tip load, but the technology of the Cyan black is a Cyan Tech. Cyan black is used to be used as a wire for the retrograde collateral crossing before the advent of the Suho wire. So with this matter, I think we are unable to see the slides, but this is a standard table which you can find from any Asahi product monograph. Next, please. So now let us understand the wire, what we used in this patient, that is the Gaia series of wire. Dr. Surya Prakash also was using the Gaia series of wire. This has got a Act 1 rope coil, and this is a spring tip wire. The importance of the Gaia wire is the tip is micro cone wire. It's a micro cone wire, and the tip is pre-shaped. The distal pre-shaping is only 1 millimeter. So it has got to make a 1 millimeter pre-shaping needs a lot of experience and expertise. So it is if you have got a pre-shaped wire, it is easy because the tip is 1 millimeter pre-shaped. You can easily track through a collateral quite easily. The importance of the Gaia series of wires is they have got a 1:1 torque transmission. So if you torque 1, it goes 1. And then the tip load of Gaia first, second, and third varies from 1.7, 3.5, and 4.5. But more importantly, the tapering of the tip is progressively the wire tapers. The Gaia first has got a tip of 010, whereas second has got 011, and Gaia third has got a tip of 012. So these wires, because of the taper tip, even though the tip load is only 3 grams, because of the taper tip, the penetrative power of a Gaia wire is much higher. So a Gaia first, second, and third, even though the tip load to a comparative wire is the similar, but the penetrative ability is much higher. And the important thing is, as we already knew, that there is a micro cone tip. The microcone tip is non-hydrophilic. The rest of the wire is hydrophilic. So it does not go subintimal so easily unless you really penetrate and push it. So, so the major advantage is we use a Gaia when you want to have a very good tip control because of the 1:1 torque transmission. Next, and then you can see here, we can move, can we go previous, please? Sorry. So if you use, you can see the last part, Gaia third is used for re-entry in the reverse cart. In the last case, I will show you that how a Gaia third can be used for a re-entry in the reverse cart. Next, please. So now the second part, we have understood about the Fielder series, the Sion series, and the Gaia series, 3 different series of wires from Asahi. And we have got the microcatheters. So of the microcatheters, each person, once again, I keep using a Caravelle, but we have got very good alternatives in the form of Corsair Pro and Corsair Pro XS. So the Caravelle, you don't need to torque the microcatheter when you advance the microcatheter. Whereas when we are using a Corsair Pro and a Corsair Pro XS, we have to do a clockwise and a counterclock manipulation. Now the tip crossing profile of Caravelle versus Corsair Pro and Corsair Pro XS is Caravelle has got a very low tip crossing profile and compared to Corsair Pro and Corsair Pro XS. But fine cross seems to have a much lower tip crossing profile. But the limitation of the fine cross is a microcatheter has to give a support to the wire, as well as it has to penetrate through sometimes a calcified lesion and all that. So if you got a collateral type crossing and all that, sometimes a fine cross seems to be a much superior option. But if you got going through an intracoronary calcified lesion, a chronic total occlusion, I personally feel that Caravelle is good. And other options like the newer generation of the microcatheters like the Corsair Pro XS or sometimes even a Tornus might be a good option for us to cross the lesion. So based upon whether we are crossing a collateral or a intracoronary CTO, so it depends upon the choice of the microcatheter varies. Next, please. So once again, Corsair Pro, which nowadays we are using quite frequently. The hydrophilic coating is there for this Corsair Pro as well as for Caravelle and Corsair Pro XS. The crossing profile and the outer diameter are nearly the same. Some degree XS has got also the same crossing profile, possibly little higher compared to the Corsair Pro. Next, please. So we will go further. Next, please. So these are the various microcatheters which are available. So one should be aware of which microcatheter for which scenario and choose our microcatheters. Next, please. Okay. Now let me go to the second case. Dr. Kantila, do we need to come back to the live case or what? Then we can take a small. So the second case is once again a similar aged person who had an anterior wall myocardial infarction, and coronary angiography showed a LAD mid-segment chronic total occlusion, but here there is no distal reformation is not there. Next, please. So you can see the electrocardiogram, and it's a very large. You can see both the anterior as well as the inferior leads. There is an ST elevation. Next, please. It's a very large LAD suggestive of a. So this is the right coronary artery, which is non-dominant, and there are no collaterals to the LAD. It's very important when you take the contralateral angio, you should see whether there are collaterals or not. Next, please. Now this is the left coronary angio. Can you click? Yeah, it is playing. So then here you can see once again there is a blunt stump chronic total occlusion of the LAD, and it has been tried a few days ago, and the lesion could not be crossed. So once again, this gentleman wanted to get the angioplasty done for the LAD. And if you can see, the distal LAD is not seen at all. Possibly we could, because the vessel is so large, I thought that the distal vessel should be there. But if you look at the CTO algorithms, if you do not see the distal LAD, either by native angiography or CT coronary angiography, you should think twice before you attempt this case. So before you attempt any CTO, you should see the distal vessel. So you should see where the segment what you need to bridge to go forward. Next, please. Next lead, please. So this patient has a high JCTO score, but the syntax score is quite low. He would be a very good candidate for angioplasty, because that shows the limitation of the syntax score, because it doesn't take into consideration the CTO, the challenges in the CTO crossing. Next, please. Next, please. Next, please. So we will. So there are no retrograde collaterals similar to the previous case. We use the same similar material. Next, please. And then what we did for this patient was we similarly taken a caravel support, and we advanced the wire. You can see on the other panel that the CTO segment is about 20 millimeter or just about 20 millimeter. So once you cross the CTO segment, the progression of the wire is quite easy. And here in this patient, we did not use a dedicated special CTO wire. What was our workhorse wire did work. So the important thing is we can see that there is a track in the upper part of that vascular lumen. This appeared because of the previous attempt elsewhere, and then that made our job much more easier. Next, please. So this was the total occlusion, and this was what we could open up. So the presence of branches is a negative thing, but still with the standard material only we could perform this procedure. Next, please. Then the third case is another different patient, where we have a 54-year-old male who presents with chest pain. He had an angioplasty to the LAD 10 years ago. He has got all risk factors. He had got LAD instant restenosis chronic total occlusion, and RCA has got a 70 to 90% stenosis. He has been referred for a LAD ISR CTO. Next, please. So some of the patients we do not have the angiographic pictures, but here you can see that there is some degree of staining in the LAD, and the LAD total occlusion is there. We thought it was, so when this patient came to me, I thought that it would, we will be able to perform it. And what we taken was the first choice of the wire, what we have taken for this patient was a routine workhorse wire. We use a workhorse wire to reach the chronic total occlusion. Once again, this gentleman also, he did not have good collateral from the contralateral approach. So that's why we did not take a dual coronary angio. So there were no collaterals at all. So we used the same microcatheter, the same Caravel microcatheter. We used a Gaia second to cross it. We used a first Fielder FC, did not cross. Then we used a Gaia second. Gaia second also did not go through. Next slide, please. So then what we used was, we used a Conquest Pro 12 with the same microcatheter support. Can you play this? Can you click on the images, please? So this Conquest Pro 12, the tip load is high. Once again, this is also a tapered wire. So the advantage as well as the limitation of the tapered wires is, if you go and advance the wire without a support, then what happens that will go quite easily subintimal. So because the penetrative power of a Conquest Pro is much high, even though the tip load is 12 grams, because the tapering of the wire, if I remember, is 0.10 from 14 to 10. The penetrative ability of the wire is much higher. So what we did was, we used a Maverick balloon to open that CTO, to make a path for the CTO going on. Then we used a Wolverine cutting balloon to open the lesion. Next, please. But what happened is this lesion where then we studied on intravascular ultrasound. The IVA showed the stent to be about 2 millimeter, whereas the vessel size was 4 millimeter. So there is a lot of undersizing of the stent, which was performed, the stenting performed about a decade ago. So what we did was we did a intravascular lithotripsy for this instant restenosis. I did not have the time to pull out the IVUS images. What happened is when we wanted to put the IVL balloon, because of the bulky nature of the IVL balloon, till now when we use the microcatheter, when we use the Maverick as well as the cutting balloon, we did not use a guide extension catheter. But when we wanted to advance the IVL balloon, the IVL balloon could not be crossed. So we used a guide extension catheter, Guide Plus, and then we did a 3.5 IVL balloon, and post IVL balloon we got almost 3.5 vessel area. Then we post dilated with a 4 millimeter balloon, and we did a 3.5 into 25 millimeter solution SLR for the LAD instant restenosis. We used a DEB for that instead of putting one more layer of metal inside. Next, please. So this is the final result. You can see that by using, by avoiding the second layer of metal, we avoided any challenges in doing the bifurcation. The diagonal is preserved, and the lesion result seems to be good. If you see closely, the distal LAD is occluded. And the distal LAD also CTO was there, and that we did not want to touch because it's at the apex, and that distal LAD was getting collateral from the right coronary artery. So it was a quite long procedure. So the point from this is the importance of guide extension catheter. Next, please. So one is, before we go to the guide extension catheter, I told you some points about the Confianza Pro. In the American, they call it as the Conquest Pro, or CP in short they call, but we call it as Confianza Pro. And this Confianza Pro 014, the tip load is 12 and the tip tapers to 009. So so it is a tapered wire, very high penetrative. Only thing is, when we are using with the microcatheter support, we need to be very, very cautious when you advance the wire, because even today also, whenever we have a CTO, I still recollect the multiple times where I ended up subintimal, and then whenever I use a Conquest Pro with a guide microcatheter support. Next, please. So Conquest Pro is for very resistant, like an instant restenosis. The advantage of an instant restenosis is because of the stent is there, it is very unlikely for you to go outside the lumen. Sometimes you can still go, but if you are little delicate, gentle, I'm sure we will be able to cross that instant CTO. So for instant CTO, my choice would be a Confianza Pro. And the control of the tip, wire tip orientation is very important. The tip curve should be very small. Usually 1 or 2 millimeter tip curve is very important. And sometimes if you want to go into an LAD or into a circumflex, then possibly a secondary curve is also required. And the penetrating power is very, very high. If you keep the microcatheter closest to the wire, if you see, when we wanted to cross the stent, we kept the microcatheter very, very close to the tip of the wire. But once we crossed that instant restenosis CTO, we did not advance the microcatheter. We just advanced only the coronary wire. If the microcatheter and the coronary wire are closer with a Conquest Pro, that the penetration is very high chances for you to go outside the vessel. Next, please. Now we will discuss something about the guide extension catheters. I had been using from Guideliner, Guidezilla, but nowadays telescope also we use for some cases. But right now I use a Guide Plus. It's once again a personal choice. A lot of individual differences are there. But because this guide extension catheter is nowadays quite frequently used in the cath lab, so I try to look at the reusability of the guide extension catheter, because the catheters are costing around 40,000 rupees. So I wanted to be little more conscious in saving some money for the patient. Next, please. So guide extension catheter for a CTO angioplasty is a very, very important thing. There are a lot of, you can, if you want to do a double balloon, you have to choose a 7 French, but people like me who do transradial CTO, we always go with a 6 French. Sometimes we go with a 7 French, but that is one of the limitations. So if we want to do a bifurcation CTO, sometimes it becomes challenging if we are taking a 6 French guideliner and want to do advanced 2 balloons, it will not go. So the limitation is, if you want to use a guideliner, you might go with a 7 French, and like Dr. Prakash is showing, you use a long sheath and then use a guide catheter which is 7 French, so that you will not encounter small challenges which can be very nagging when you do the CTO angioplasty. Next, please. So what will we do? Can we go, or can we? Yeah, we will try. We can wrap it up. That's also okay. So this is a lady who had a RCA osteal CTO. Once again, next please. Next slide. We will see. This is the last case. What I will show you. This lady had an osteal RCA CTO. The angio was done elsewhere, so I cannot. I could not capture the angio, but the RCA was the CTO. But why I wanted to share this long angiographic projection is, sometimes when you do not have an angio, as much as possible, as I was telling you, we avoid the antegrade angios. So we just trying to cannulate the right coronary ostium. We are trying to pass the wire. We take the microcatheter, and then the microcatheter is at the tip of the guide catheter, and then from there the upper part of the right corner is entirely calcified. You can see the entire RCA is calcified from the ostium up to the mid segment. So we were just trying to pass the wire. So we just this is all one fluoroscopic projection only. So this was a fluorosave which we have done. So when we tried upper part of the lesion, it was not going into the lumen. Then we tried from below up, it was not going up. From above down, we are trying. Now you see that we are trying. We cannot go selective because the ostium is completely occluded. So we are just passing the wire outside with a non-selective angio, and then we pass the wire with the microcatheter just at the tip of the guide catheter, and then we position it. I will just show you. Sometimes we have to this wire, if I remember, was a XTR, if I'm right. So we just went down, and so when we go deep in, it is going and hitting the wall. So we had to come back and do the angio to pass the wire. Now you can see that just cannulating, and then we are going down the wire and then advancing the microcatheter. So you can see that there is a lot of resistance because of the dense calcium there. And once the microcatheter is advanced, then the problem is the CTO segment is very, very hard. And it is from the ostium. Once we cross the CTO segment, the progression of the wire is very rapid. So, and then we are advancing the microcatheter also in tandem with the wire progression. And sometimes it seeks the side branch like what you see here. And then once we come back and then find the true lumen and cross the lumen. So it was taking about 1.5 minutes for us to get into the true lumen and come into the distal right coronary artery. Next slide, please. So with this microcatheter across, we did a alveo HP balloon. So we should have low profile balloons like we have got the alveo HP. I find it very good because for a CTO, it is a very good balloon. For a non-CTO lesion, I use a Maverick 2. Even though it is a very old generation balloon, the crossing profile is very good and I have a very high success rate. Even with a 1.5 also, I will be able to cross many lesions. Whereas, but for challenging lesions like this, I take a HP because it is a high pressure balloon and a CTO balloon. So we go up to 20-22 atmospheres with a 0.75 and then go with a 2.5. Next, please. So once we cross it, the angioplasty was, I thought it was simple, but we could not go. We dilated with a 3.5 NC balloon. Then we went with a, next slide, please. We went with a intravascular lithotripsy. So next, please. So when we wanted to go with a IVL balloon, once again, there's a lot of calcium. So we need to do a, we need to use a guide extension catheter in this case again. And after doing all that, unfortunately we had to, something it flipped off everything. Then we had to restart again the case, as you can see in the adjacent coronary. So this patient, at that point of time, the C2 plus was not there. We had to use 2 IVL balloons to complete the angioplasty for this patient. Next, please. Yeah, and this was the final result. And this patient, if you see here on the right panel, there was a persistent narrowing of the ostial CTO. The stent was still not expanded well. So we used a, what is that, open NC balloon, and we went up to almost 35 atmospheres and opened that ostial lesion instant with an open NC, and then this was the result what we got. So this patient, we had to use 2 IVLs, a lot of microcatheter, 1 microcatheter, guide extension catheter, 1 coronary wire, despite crossing, because ostial RCA CTOs are quite challenging. I had 1 more ostial RC CTO around this time, which I could not cross, where I attempted a retrograde. I failed. I did not. As usual, we don't show those cases because I did not try enough also. The problem for the CTO is the budgeting of these patients. So with this, next slide, please. So, one should be having a very good idea of the various low profile balloons. So majority of the companies have got the low profile variants. Sapphire has got Sapphire 2, Sapphire 3, low profile. Alveo HP is there. Nick Nano is there from another Swiss company, and then we have the we have 1 millimeter balloons from even from Medtronic also. So each company, there are some Acrostat CTO balloons and all that. So over time I used many of the balloons, but right now my personal choice is a Alveo HP for crossing these patients. Next, please. Crossing these lesions. Then finally, the Alveo HP has got a very low crossing profile of 0.019 or something. The Nick Nano also has got similar thing. I think each one claims that he is the best one. What you are comfortable is the one what we need to use. Next, please. And OP and NC also, because that comes with a dedicated indiflator which can go up to 50 atmospheres, which we can go. Next, please. And Nick Nano balloon, if you want to go for an alternative to the Alveo HP, what we can use. Next, please. I think with this we will stop here. In case if you have some more things are there, like the coils, covered stent, and all that, we can discuss in case if you have a delay in the case.
Yeah.
Is the retrograde we thought of trying only 1 collateral, which is at a awkward bend. If you see that second collateral, go with the collateral again. No, not that collateral. No. Just show the collateral. He's showing the collateral from the areocranial view. You see that there are 1 collateral joining the PD.
Yeah.
But it is at an angle just below the diagonal. If you carefully notice, there's a calcium at that diagonal.
Yes.
Okay. So
Right, and the stenosis is also there.
that is maybe you are underestimating the stenosis there. And then next, we have a Corwell, we have a Corsair XS, but I took a Corwell here, and with a routine wire run through to enter the collateral. You see now, I could enter the collateral, but you see there is a acute angle and calcium which the Corwell catheter is facing resistance there. The guiding catheter is coming out. That's why at this stage I know it will be difficult. Even I go retrograde, reach the C2O segment. Taking the microcatheter is not easy. Because the very bad angle and calcium there. So in hybrid approach, people should know that you need not stick to the same thing. So I went ahead again anti-grade. You see, what I have done is the first wire filter XT is in the architecture, and the second wire Gaia 3 is actually I tried Gaia 2, Gaia 3, Mongo wire, and it is just beyond the architecture. I am not happy with that. So I went ahead with a very good, my favorite wire, Ultimate Bros. So I made a little tip bend at the Ultimate Bros. Tip bend at the Ultimate Bros. If you can see that now, they are close together. They are close together, both wires filter XT and the Ultimate Bros. I have given a retrograde injection. Next, I made that curve. You see that curve helped me. That curve would help me to cross the distal cap. Next. So my wire is in the distal true lumen.
What was the tip load of the Ultimate Bros? 3 or 6 or what?
3 grams. 3 grams.
3 grams. Okay.
3 grams. So then after that, I try to push the carbell. It is not going. It's a very calcific lesion. If I try to push the carbell here, everything will come out. So I decided balloon trap. I took the this thing out. I checked the left system. There's no damage to any collateral. That's most important. Then I dilated with a 1.5 and 2 millimeter balloons. And I was done IVUS after that. Mr. Ravi is showing the IVUS. You can go to the IVUS. The distal vessel, you can tell, distal vessel size is around 2.5. 2.5. And if you can see at the CTO segment, long segment actually, diseased segment, and calcium at the 9 o'clock, 6 o'clock, and
Can we have the IVUS image, please?
please, IVUS image, please. How you get IVUS image?
Can you show only the IVUS image instead of the
IVUS.
screen? Instead of the cath lab screen?
Meanwhile, we are monitoring the ACT at regular intervals. People should know every half an hour I see
Yeah.
the ACT.
Can you play this, please? Yeah.
So the IVUS, you see the distal vessel is around 2.5, and there's a calcium from 5 to 8 o'clock, and there's again there's a branch coming there, and at the segment of the CTO, it's a very dense calcific lesion. You can see that multiple planes of dissection. You can see in the calcium broken with the balloon dilatations, and eccentric calcium also in the media intima. That's why this lesion troubled a lot. Ideally, a retrograde procedure is ideal in these cases, but you see, the lack of good collateral made me to rethink in this case. The proximal size is around 3.5 as per the IVUS. That is the thing now. Now we go ahead with the 2.5 balloon and put the stent there. 2.5 balloon. I think he needs long stenting in this. What do you feel?
Yeah. I think one, because there is a long segment, one can measure that because you are an automated pullback. What was the length of the lesion, Mr. Ravi?
Only the message I want to convey that once antigrade you try, you fail, you go to retrograde. There's nothing like that you can come back. That's what the hybrid procedure says. But your steps should be faster. Don't waste time too much on the subintimal plane. Don't waste time on the too much on the collateral. Always think about some other techniques to not to waste much time. So the fluoro time, the contrast, the procedure time comes less. Patient's outcomes are better. What could have been the options if I don't have even that collateral also? So I would have passed the IVUS catheter onto the wire which is in the subintima, and I could have done a IVUS guided re-entry. So because we have done many cases, I'm confidently I can push the wire, but that's the ideal way. Sometimes IVUS guided subintimal to entry, and I can have put a recross catheter. We got now a recross catheter also. I could have put the recross catheter, and we could enter the distal to the obstruction. cap, you can enter the recross. Like a stingray, no need to use cross passer stingray. Recross catheter also we can do.
So you did a parallel wire with the ultimate bro wire.
3 wires together at that
Three
time.
wires.
Yeah,
Three wires in parallel wire. Okay.
one it's like water that train accident of Balapura. It's like three wires together.
Mhm.
There XT one guy and then this thing. You delete this segment now, CTO segment.
So you want to do some calcium modification, or you want to?
I think it is expanding here with a 2.5 NC balloon.
Mhm.
Uh, the balloon is expanding smoothly. 10, 12, 14, you can. Okay. Here also.
Dr. Surprakash, you must have been visiting so many centers and performing CTO angioplasties all across India. What are the, why do Indian operators, actually globally also there is a reduction in the retrograde, but why do we don't quickly go on to a retrograde like what the Japanese do? What are the challenges what we have?
No, they are also not doing retrograde fast. Nowadays, their number has come down, retrograde.
Mhm.
Japan also. Because of the unnecessary donor artery injury and perforations.
Okay.
That's why they're also, because the many wires have come up, like Miracle Neo is a wire where hydrophilic wire with 3 grams. It's like a ultimate boss, but it's a very good wire for them. Like they got the Gaia next wires. We don't have
We don't have Gaia next.
the
Yeah.
Gaia next wires and Miracle 3 wire. There are many new wires have come up for them. That's why their procedure time they are cutting shorter. But as you said, if somebody having a CKD and you don't want to inject much contrast and there's no option, the osteal lesions, like tomorrow, both are osteal lesions, absolutely zero. So there's no option. We have to do retrograde only. The both cases I posted tomorrow because of the time in this thing. Both are retrograde cases. No option to do antigrade. So their cases we don't have options.
I think it's the right approach only. It should be last resort, the retrograde. Because retrograde always, however, best hands you have, still there's slightly more complication rates. So always try antigrade after you exhaust everything, only people should go for retrograde.
Only thing, if you form too much hematoma, then the failure rate is very high. We have to end up the procedure. That is one risk in antigrade when
Distally in the vessel, I was showed 2.5, but angio-wise it looks little bigger. Maybe spasm was there.
maybe as you said,
Long,
TG and we can do that. Yeah. Anyway, 2.48.
long occlusion, the spasm and diffuse thing. Maybe after you open up, you take NTG and then take a proper picture, then decide size of stent.
Doing I was.
The concept that in the RCOA, everything is in one groove. The size may not change from the proximal to mid and distal cylinder. That's why unless you think twice to put 2.5 in RCA before.
If you see, the proximal RCA has a calcium and a bend. So always this amplified catheter is the catheter of choice, but at the end you have to put the stents from the ostium. Most of the RCA CTOs we end up putting from the ostium because we use guidings, we need strong support. If you notice, once I engage the guiding deeply only, I could manipulate the wires in this particular case. That is actually one of the success in the last attempt when I'm trying what to do to search for another collateral, or I do a knuckle and do the recross distal reentry. These things are coming into the mind. That time I just deep throated the guiding. That has given more support to manipulate the wire better. If we see at the bend of the RCA, there is a calcium. You can see that there's a acute bend. Save that.
Two stents per
We
case.
deploy here. No, no, it's okay. I think sufficient. You can deploy.
See the good nature of the stents now. So much tortuosity, but still it goes. Sometimes you've seen the balloons won't go NC balloons, but stents go because they're deployed.
The present distance, what you said is correct.
In one way, lesion is not prepared well. You take stents and stents won't expand. It's a challenge sometimes. That's why it's always better to dilate, prepare the bed and take it. Here, the such much tortuosity, it is I don't know what stent, but went very well.
Alpine, 48.
Yeah.
In the proximal portion, what is the size? So we take a 3.5. 3 we take a higher. We can take.
You can take a 3.5 stent at least and then post variant this one.
We'll do that. So when I do this, I just bring up some caudal view. I bring out the guiding little bit out, see the any dissection, whether I have to cover the ostium also. That part I will see.
Ostium is okay, I think. Just to distal to the ostium, the tapering is starting. That from the branch, one small.
Just injecting, putting the guiding out and giving. That's what. Maybe you give 3.5. Better 3.5 you give. 3.5. 3.5, 28 you give. That's right. No problem. I will post there later. You feel that calcium have to prepare before putting the stent at the CTO site? What do you feel, Raghu?
Yeah, actually, some degree of calcium modification is important in this patient,
So-
especially with a CTO. That's number one, and
I
it's a
agree.
tortuous vessel,
Ah,
and we don't want to have a restenosis. I think the
Yes.
emphasis has shifted to lesion preparation.
Yes.
That's what I think is.
I fully agree. I will do with a scoring balloon this one and 3 angioscopic view.
How do you choose your calcium modification strategy after the IVAS, Dr. Surprakash? I will ask Dr. Srinivas Kumar, and after that we'll.
Actually, this scoring balloon angiosculpt, whatever is saying, I'm not very greatly happy with it because though it is has a wire and things like that, profile wise it's low, but it is not as good as Wolverine, things like that, which could have better preparation and better opening up. Definitely angiosculpt has a lower profile, but I don't know, but the results wise, how much better it performs. Calcified lesion approach wise, as you said, because you first decide on whether it is occlusive calcium or not. If it is occlusive, then probably you root ablation orbital you take. Otherwise, if you take a balloon, initially small balloon can go, then you take a bigger sized balloon. And then if NC is not working, then you go for OPN, but OPN again is a bulky balloon. So then if a calcium is all 360 degrees around and then more deeper also, that's where we prefer IVL balloon. But the only thing is costly, expensive nature of IVL balloon. It's a bit difficult.
Very
Otherwise,
because in CTO use all new material. I never use the G because
yes,
we'll
yes.
fail, using the do it here.
But how do you think Wolverine balloon is compared to this angiosculpt balloon? What you're taking? Angiosculpt low profile, agreed. But I don't know how much it will open that calcium.
People use up to 18 atmospheres. Seeing.
Yeah.
Then.
What is the typical pressure, Dr. Srinivas, when you go?
But I've seen more dissections with Wolverine. What I see. Morning also I use in the case. I took a long stent after using the Wolverine after opening the CTO. I thought of doing 2-spot stenting, but I have to use a long stent.
Actually, exactly they say the opposite because if you use Wolverine, They claim the dissections are less common because of cutting nature. I don't know.
You have a bifurcation lesion, LED diagonal. So modification is diagonal. Which one you prefer, angiosculp or Wolverine? Wolverine.
If
At the carina area.
if the calcium is heavy and it needs a good dilatation, I take more tougher balloons like Wolverine or OP and things like that. Angiosculpt somehow I feel it is okay for some milder things, but not for heavy calcium.
Okay. Now take the 28 3.5.
Actually, when we do a Wolverine and then examine that with the IVUS, we tend to see the dissections. But the most of the time, the IVUS dissections, what we see are not a important dissection to cause a vascular occlusion. The mechanism is it creates longitudinal cuts, and cuts are only dissection. So nowadays, I move to some degree of metal-free PCI. So in those cases, these cuts are very important. So we use the Wolverine for the cutting to cut and for the drug to go and act.
So you want to take 3.5?
No, sir, 3.5.
I'm asking 3.5 only. 3.5. then. Size is big. Actually, it is 4 above.
Proximally, you'll stent will end that proximal to the conal branch, the bigger branch which is coming up, or you want to come up to the ostium. I don't think ostium coverage is important. Is needed, no? Just distal to the ostium, we can start.
Exactly.
But I think if you see the result after the angiosculpt looks to be almost near to a stent-like result.
What about the regulating balloon and
Yeah, no, I'm saying with the result is reasonably.
yes, that's again old fashion has come that you put that regulating balloon. Babu, I think. Get the guiding.
So this is a 3.5.
This is a 3.5. Overlap వచ్చింది కదా? I think correct. Overlap వచ్చింది. Stent overlap.
We can do one stent boost or something like that to see the overlap clearly.
I think overlap has come, but they say wire to be deep throat, then stent will go. Okay.
So I think you had overlapped the previous stent.
Yeah, that's why his doubt is trying to check. He can do the stent boost or stent is whatever. I think it just entered.
Stent should go smoothly into the artery. That's what I am aiming. The guiding little because it lost the that.
The stent struts also hold up.
Maybe stent starts to be opened. Balloon ano, just guiding later. What is in the guiding? Huh?
Yes.
We'll open the struts little bit. Now I will test it. That's another way. Do it. Save.
Got it out
Deep
totally.
throated. I deep throated and there is sufficient. I can see the stent overlap is there. Okay. Overlap. Now I am drawing
Proximally, I
the.
think we should check because proximally it needs to come back.
I think distally wherever it goes overlap and then pull back.
GL. అంతే చాలు
It's covered.
కొంచెం చేసి
మార్చుకోండి అటు ఇటు
అయిపోయింది. కింద కంటెస్ట్ చేసి
సెట్టింగ్స్ 2 4 6 8 10 నామినల్ సార్
ఓకే. ఇంకోసారి చేస్తా.
8 10 సార్
టేక్ ఏ 3.5 balloon.
Go more high pressure, I think. Artery is big.
We'll go with some other balloon.
What is your balloon here?
There pot balloon is there. Pot and the pot balloon.
What are the?
Not a pot balloon of Spectronics.
But that is more for bifurcation where the proximal size is bigger and it has a doesn't have shaft. Doesn't have floaters.
Any NC balloon you can take. 3.5 any NC balloon.
Similarly, I also started using the pot even for a non-bifurcation. What I felt was
Fine.
the balloon has a little larger profile, but
Open change.
get a very good post dilatation. What you get with a NC versus a pot, I think you get a very good angiographic expression of this kind.
ఈ catheter తీసేద్దామా?
But in such a long segment
Yeah,
where you need
that's what
you need multiple
the
places.
10 millimeter
Ah.
pot balloon or 8 millimeter.
Yeah,
5
little
and 8 are
little
there.
longer
So
one is
8
better.
is you have to take 8 and then go with that. As an advantage is, I think the material what they use for the pot balloon is different. The polyethylene. NC balloon. So the NC balloon versus the pot balloon, I started using it. Then I realized that the stent expansion and once we do the IVS and all, the result is much good. I think it's a different structure.
14 billion.
Balloon, yeah. For example, you do a OP in NC, you have a double layer of balloon. So OP and NC, you have that structure same balloon. Similarly, the material what they use for what is yeah.
Shoulders are not there.
That's what they sell. When I was sitting with them, then I was understanding that where all we can use
No
this.
problem. Here I can do. Yeah.
It's a very nice balloon for doing this proximal lesions and all.
8 10 12
14.
14
You can try. It's a very good option.
అది 2.5 కదా స్టెంట్ చేసాం కదా
That's the only.
ఓవర్లాప్ నేను చూడలేదు అయితే చేసాండి ఇదే కదా
కిందికి వెళ్ళాలి సార్
Box.
దిస్ balloon is not
It's like
good.
apple. How apple looks on the other side, there is indentation exactly like apple it looks once it's so inflated.
Very nicely it explains the stent. That's what I observed.
వెళ్తుంది బెలూన్ ఏముంది లేకపోతే ఇట్స్ నాట్ గోయింగ్ 3 బెలూన్ ఏమన్నా ఉందా Another line.
Actually, this Saturday, we had a section on bifurcation. So in that, it was a normal
And
NCP
balloon man.
by Sabian Dr. Kandar,
The 3 balloon will do that.
protection specialist. So he showed a case where he just was there only. Once you go little high, like what he's telling you, the balloon little elongated and
I was this guy.
cross the carina. And then
No,
after
niche is I was better.
the
Come on.
osteum got deformed and all those things. So they
And
definitely
కావాలంటే కొంచెం వాటర్ ఇస్తే
once you go very high,
సిప్స్ వాటర్
doesn't
కొంచెం వాటర్ ఇవ్వడానికి
Always the step two, step the end in the middle is of, okay, you can go whatever you want, but the starting from the point need to be exact all the time. That's why it. What happens is that express and out, so we end up going constantly.
ఏం వెళ్ళింది
Doing final IVAS, sir, no? What are you doing?
No, sir, just going with that
Another balloon.
that overlap I am stretching. Please.
6, 8, 10, 12,
14, 16,
16.
18. Yes. సరిపోతుందిగా చేశాను కదా ఇంకేం ఓవర్లాప్
కింద చేసుకోవచ్చు సార్.
చేయండి వెళ్ళిందమ్మా వెళ్ళి చేయండి
10, 12, 14.
చేయండి అదే ఓవర్లాప్ చేయండి అదే కదా ఓవర్లాప్ తీసే ఓకే అక్కడ చేయి గొడవ ఓవర్లాప్
8, 10, 12,
14, 16, 18 చాలు ఓకే ఐవాస్ తీసుకోమా ఐవాస్ తీసుకోండి అయిపోయింది
ఆర్డర్లోకి ఉంది.
ఐవాస్ తీసుకో
అది సార్.
I'm not injecting much contrast. I'm doing under fluoro. These are very important things. I'm not giving much antigrade injections. Even that Hayashi suggestion, my personal view, I never give, even with microcatheter, to check a channel.
Yes. Here.
తీసుకోండి పర్లేదు అయిపోయింది ఆయనకి ఏముంటాడు ఉమ్మా ఎల్బి డిస్ఫంక్షన్ ఏం లేదు కదా ఓకే Raghu, are you able to see IVAS?
No,
As of now, we cannot see.
Just we are putting the IVAS there.
Yeah, we can see. Can we have the IVUS the largest screen, please? We can show only the IVUS.
ఏమన్నా లంగ్స్ ఆస్కులేట్ చేయమనండి కాప్ చేస్తున్నారంటే ఒకసారి లంగ్స్ ఆస్కులేట్ చేయండి.
What is that one? Beyond that is hematoma. That was the hematoma. I think it needs little more. Yeah, that
That
was,
is a hematoma.
that was the hematoma from the previous thing. Yeah, now it's better. Yeah. The stent expansion seems to be good, and opposition also is good, and there is no under expansion where the calcium is, and it is a circular stent. There is no oblongity or as far as the stent expansion is concerned. I think it is good. Only when you go more proximal, I think here there is some degree of gap is there. I think here you at some segment, I don't know where you are on the fluoroscopy. At the proximal part of the stent, there is some degree of little more work. Here you need more work. I think there is a gap still there. You need to cover that. Yes.
More side there.
Yeah. So possibly you need to take 4 millimeter or a 4.5 balloon and then.
4
Yeah.
4.8.
2, 3, 4, 4.5. It is 5. It is coming almost around 4.5. All this segment where there was a calcium, it is still, it has to be expanded better.
No, that is filling properly. It's a phasic filling. And the IVUS it expanded nicely. Only 5 proximally we have to do.
Even you can take a 4.5, Dr. Prakash.
4.
4, okay.
ఎంత వచ్చింది 5 4.5 ఉంది IVUS
At least 4.5, definitely 4.5.
4 ఇవ్వండి. I think it is okay.
Basically, also the vessel was looking for there.
Okay, that filling RV branch is gone. Did you observe that?
Yes, it became bald.
Bald. And that's what I noticed with certain stents, side branches is a problem. Or you have done at that segment any false, if the diver shows false lumen partially there, the stent in the false lumen, you could have lost it. Both ways.
Small hematoma around also could be one.
We have to review that.
Just to dilate proximally the four-sized balloon and then.
I know.
Rather than doing too much. Patient is having breathlessness. Some drugs you are selling. You should keep that also in mind.
He's fine. Change sister. He is fine. Nothing.
Now you can show the cine, please. Now we are seeing I was still the recording one. You can show the live cine.
14, 16, 16, 18. Bus. Stent boost ఒకటి చేయండి దాంట్లో ఉంటుంది. He had some COPD, otherwise he is okay.
Okay.
Sir, normal heart rates are good. No ST changes. Okay. Good only. I think we should leave that.
Yeah.
Good only. Hello, cranial you go. I'll give one shot to come out. I think this is the result what we can achieve. Caudal V1.
It's a very good job. Dr.
Very good result. Congratulations.
Thank you.
What you started with, I think quite a few of us have joined little late. You should show the pre also.
We inject the groin and we'll close with the angioceal. This one.
Okay. So we can, next session would be by Dr. Nasraza and
Inject and we'll close it. Okay, ఎక్కువ చేయించండి ఇక్కడనే. Angioceal తీసుకోండి.
Tough case. Another tough case, sir.
It's a tough case, real tough case.
Very good.
Hmm.
Prakash sir, are you hearing us or disconnected?
Good to hear.
Yeah. I think you have shown a great case demonstration of occlusion. Initially, we thought there's a faint antegrade track. Try to cross with a softer wire. Because of tortuosity didn't go, then you tried to change the technique to more stiffer wire. It went into false track, but you went on to retrograde. But because of tortuosity and calcium in that collateral, you came back. That's what the approach what you're mentioning was take quick decisions and switch both ways and don't waste time too much on radiation. Then finally, by using your ultimate boss wire with the shaping of the wire. Initially, also I was thinking you're almost there with tip shaping. You could have entered the true lumen. That's what I think helped to enter the true lumen. Then calcific lesion was demonstrated by IVUS, which was prepared very well. And then probably latest quality stents went tracked very easily in spite of all the tortuosities. And Amplatzer guide also helped. Finally, the bed preparation and then probably optimization of stent expansions was also very important in tackling such long lesions. And proximally, there was some slight malapposition. We thought that was again tackled up with 4 mm bigger size balloon stent. And final result is good. And is closing the femoral artery with the closure device. Congratulations. And I think we'll break here.
Thank you for your excellent discussion, interaction.
Thank you.
You and yourself. It enlightened me and the audience there. For this case, new ideas have come and that ultimately results in better outcomes.
Thank you, sir.
Thank you.